afternoon, everyone. My name is Denise Manonis. I am the Assistant Vice President for External Affairs for St. John's Riverside Hospital, and it is my pleasure to welcome you to our Riverside Talk presentation. Today's topic is first signs and impact of stroke on your mind and body. And before we get into our program, I would like just to take this opportunity to thank my team who produce and set up all of the presentations that we do. Jason Latore is our media production manager, Nancy Nabi is our community liaison, and Candace Cousin-Hopkins is our associate director of external affairs. They each play a very integral role in making these productions happen. So thank you to the team. Today we are welcoming Dominique Petit Frere, our new stroke coordinator and clinical resource today. But before we get there, I'd just like to let our audience know that if they have questions that they would like to pose that maybe don't get covered during the course of the discussion, they can absolutely put a question in to our Q&A, and at the end of the presentation, I will look at those questions. If we haven't covered it, I will ask that question for you. In the meantime, I would also like to acknowledge our original partners in this endeavor, the Yonkers Neighborhood Naturally Occurring Retirement Community and the Yonkers Public Library. They have been extraordinary in helping us get the word out about these webinars and getting an audience for us for these programs. We also have new partners who are doing the same thing for us, and that is, I'd just like to acknowledge them. The Ashling Irish Community and Cultural Center, the Department of Veterans Affairs Services for the City of Yonkers, Ardsley Parks and Recreation, Ardsley Senior Center, Bronxville Community Center, the City of Yonkers, Community Baptist Church, Hastings Community Center, Irvington Community Center, Westchester Jewish Community Services, and Yonkers Pathways to Success. Thank you again for all that you do to help us get the word out about this. And now I'd really like to take a minute and introduce our speaker. Dominique Petit Frere is a dedicated healthcare professional serving as our stroke coordinator and clinical resource here at St. John's Riverside Hospital. She began her academic journey at New York University's Rory Myers College of Nursing, where she earned a Bachelor of Science in Nursing and was a recipient of the Louis and Rachel Rudin Foundation, Inc.'s Nursing Scholarship. Dominique is currently pursuing her Master of Science in Nursing as a psychiatric mental health nurse practitioner at Pace University and plans to focus on post-stroke depression as an NP. Dominique's nursing career started at Lenox Hill Hospital on a medical surgical unit, where she quickly became a charge nurse and then went on to train as an open heart surgery ICU nurse. As a stroke coordinator, she leverages her comprehensive understanding of stroke conditions to care for her patients. Her experience includes working collaboratively with patients, healthcare providers, and support departments to ensure the delivery of high quality services. So Dominique, thank you so very much for being with us today. And without further ado, welcome to the show. And let's jump in with the first question. Hi, how are you?
Hi, thank you. I'm good. I'm great. We're excited. We're very excited. Wonderful. So thank you for having me.
Of course, of course. So let's start first with the role that you're playing as a stroke coordinator. Can you tell me a little bit about what's involved in what you do?
Sure. So my role here as a stroke coordinator is a very unique role. So what it includes is being a liaison for the hospital as well as all of our reporting agencies, which include the Joint Commission, New York State Department of Health, as well as the CDC. As well as New York State Department of Health, like I said. So these overseeing agencies, the hospital reports all of our stroke guidelines to them. And so my role is a liaison. So overseeing the stroke program, I make sure that every patient that is a stroke or a possible stroke receive all the timely and effective stroke interventions. So that includes compliance with all of the stroke guidelines, as well as educating the staff, the community about stroke prevention and treatment, as well as working to improve patient outcomes through quality improvement projects and initiatives. So it also includes reporting to the stroke registry, which is a national registry for the American Heart Association, which has all of our data to make sure that we're staying compliant with all of our guidelines.
Wonderful. So that's a big job. I guess as the coordinator, you're sort of leading the charge, but you are working with a team. And so could you tell us a little bit about the members of the team and what they do?
Sure. Taking care of any patient, but especially a stroke patient, it's a multidisciplinary approach. So what it means is different disciplines are involved in the care of a stroke patient. So I know last week we had our stroke fair, and it was established in that way. So from the first table, which was the ambulance, as well as the emergency room and all of the different disciplines that are involved in a stroke patient. It's a whole team effort to take care of a stroke patient. So that includes the emergency medicine, neurology, radiology, nursing, rehab services, which is physical, occupational, and speech language pathology, pharmacy, social work, case management. Each one of these team members, they play a critical role and really the rapid assessment, diagnosis, treatment, and post-care of every stroke patient. So we want to really have everyone understand that it's a whole team approach and the management, the care, the treatment of one stroke patient. A lot of departments are involved.
That's really fascinating. So let's step back from sort of the processes here, and let's talk first about the different types of strokes that there are so that the audience understands what's different about them. And then we can a little later on, we'll sort of take a patient through the process. But different types of strokes.
Sure, that's a very common question. So there are three main types of stroke. The most common type is an ischemic stroke. So what it means is the stroke is ischemic in nature. So it means that it is caused by a blockage in an artery, right? So an artery carries blood from the heart to your organs, which includes the brain. So when there's a blockage in that artery that supplies blood to the brain, it is often due by a blood clot. So you'll hear that term ischemic stroke. So that was caused by a blood clot in the artery that's blocking blood to the brain. The second most common type is hemorrhagic stroke. So what it means is that when there's a blood vessel in the brain that bursts, it leads to bleeding either in the brain or around the brain. There's also a TIA, which is a transient ischemic attack. So it is an attack. It is not, it is often called a mini stroke. The difference is that it is a temporary period where the symptoms align with an ischemic stroke, but it resolves. The symptoms do not stay. So because of that, it's just an attack. But it's very important to know that when there's an attack, it's often a warning sign for future strokes. So we do act as well and prevent future attacks. So once we see that, it is also a warning sign for a possible future stroke.
Okay, so that's very interesting. I didn't realize there were three types. Let's talk about the warning signs because they are very specific, although there are certain humans that present in different kinds of ways, but they are recognizable, I guess is the word. So can you kind of walk through what some of those signs are that people might be watching in someone in front of them so that we can understand how to recognize it?
Yes, that's a very important question. So the warning signs of a stroke, to simplify and to be easily remembered, it can be remembered with the acronym FAST. So that's FAST. So with FAST, these are the common warning signs of a stroke. So F stands for face. So if you're speaking and having a conversation with a person and you notice that they have a facial droop, right? So one side of their face either drops or feels numb. You can ask the person to smile to see if it's even, right? If there's a slight difference, for example, it's no longer symmetrical, that is a common warning sign that this person can be possibly having a stroke. So as well as A stands for their arms, right? So you can ask them to lift both arms. And if you notice that one arm is noticeably, it feels either weak, numb, or they're not able to raise both at the same level, and if they do raise both of the arms, one starts drifting downward. That's a possible warning sign that they could be experiencing a stroke.
Okay.
We can also notice their speech, which is the S part of the acronym. If you notice that their speech is strange, right? So we can know when a person's having a normal conversation, what their words are supposed to sound like. But if you notice all of the sudden there's some slurring of their speech, there's strange noises, either they're not able to even get any words out, or they're speaking, but it is not making any logical sense. We want to ask the person to repeat just a simple sentence. And if there's some kind of difficulty, that's also a warning sign. And then lastly, T stands for time in the FAST acronym, right? So if you are not in a hospital, or if you are in an outpatient setting, if you notice all of these signs, it's very important to move fast and to call 911. So T stands for time. We want to make sure that people are aware that time is crucial in stroke treatments, right? We want to call 911 because we want to delay any type of care delays to be able to save the brain.
Right. So that, I mean, I actually knew that fast in this instance means don't fool around and get to a hospital, because the timing of treatment can impact the patient's long-term wellness. Because if it's within a certain amount of time, they can be successfully treated to a point where there's almost no side effects from the stroke. But human nature being what it is, and I just want to address this. I know people who've had strokes who didn't. They kept saying, "Oh no, I'm fine. I'm fine. I'm fine. No, no, no," and then people around them didn't realize that they needed to press the issue. So do you still see that that's a typical thing, that people delay because they're like, no, 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 I'm fine. They protest. They don't want to address it. Is that something that you're seeing?
Yes, it's actually a common reason why people delay in coming to a hospital when they start experiencing a stroke symptoms, all of the symptoms that we spoke about earlier. I think that especially while we oversee in the emergency department, we see that some patients come in, they perhaps weren't feeling like themselves. They notice all of the signs, either the facial droop, the slurred speech, the weaknesses, but they think that if they perhaps just go to sleep or sleep it off, that these symptoms would resolve. So it is not a normal process for example, somebody's face to start drooping. So if you see those signs, it's very important to move fast because there are so many interventions that we can do here in the hospital that they're time sensitive, which means that if you decide to take a nap and you show up 6 hours, 10 hours after, we're very limited as to what we can do to help you. So it's very important that when we notice the FAST acronym, the signs and symptoms of a possible stroke, that we come into the hospital, we go through the emergency room or an ambulance, and we're able to get a scan of brain imaging read of your brain to make sure that it's not a stroke. We would rather you come in and we do all of the testing, and we also provide interventions if we have to, rather than someone decide to sleep it off or take a nap and they think that the symptoms will resolve, and then you come in and it's already too late and we are not able to provide those interventions.
Right. So the lesson here is really to err on the side of caution, go to the hospital and get treatment for those symptoms rather than wait too long and have now just dealing with the effects of the stroke. That can't that attack can't be resolved. So I think that was worth, you know, a little bit more concentration on that. So let's take the audience through what happens. So somebody knows they're having a stroke, or they have the symptoms of it, or some family member looks at a family person and they recognize those signs. They call 911. Can you walk through the process? What happens with the EMTs? What happens when they get to the emergency room, et cetera, down the line?
Right. So typically what happens is that a person may call and they're telling, they may give report to EMT and let them know that they're possibly experiencing a stroke. So the paramedics, the EMT, they'll come in, so they'll see the patient, they will do their assessment. They will decide sometimes a SLAM score, or they'll use their special tool to be able to decide the severity of the patient's symptoms. And depending on that assessment, they will take the patient either to a primary stroke center or a comprehensive stroke center, just depending on their assessment and the type of care that this patient might need. So once they come into us here at St. John's Riverside Hospital, so what we do in the ED is that the provider, the doctor, or the PA would quickly assess the patient. And based on that assessment, we would alert our hospital's wide system by saying that this is a possible stroke patient through a stroke alert code that's called a code gray. So once we make that announcement that there is a code gray, which is a possible stroke patient here at St. John's, this unlocks all of the emergency, all of the system-wide emergency response, so we're able to provide care without delay, without any delays. Just as we spoke before, with stroke, every minute counts. So we want to save the brain as much as possible. So with the stroke alert system, we're able to take the patient to our radiology system, our radiology department. They're able to quickly get a CT scan, which is a brain imaging read of their brain to make sure that there's not a bleed. And we can also have the ability to do an urgent MRI of further imaging of their brain. And so depending on the results of those tests, we're able to administer different treatments and different medications to be able to make sure that we're safely providing the care for this possible stroke patient based on the New York State Department of Health's guideline, as well as the American Heart Association and the Joint Commission's guidelines.
So can you talk a little bit about the treatments? Because there are some really spectacular treatments for people having a stroke occur, and that can really make the difference in the outcome. So can you talk about those treatments, medications?
Sure. So we'll talk about just the general educational treatments that are commonly provided to possible stroke patients. So once the CT scan is read, if the treatment team decides that the stroke is possibly ischemic in nature, so the treatments include providing a clot-busting medication. Here we provide TNK. We also had provided TPA before. So TPA, TNK, they're tissue plasminogen activator. They are clot busting medication. Remember, I was telling you that most strokes are ischemic in nature, which is when a blood clot stops the flow in an artery, right? So when that happens, we want to get rid of that clot. So we can provide TNK. So we have the ability here at St. John's as a primary stroke center to provide this medication. So with this medication, if it's administered within the time frame, which is 4.5 hours, from their last known well, which is the 4.5 hours from the last time this patient was feeling well. They were feeling like themselves. So with the quick administration of this medication, like you were saying before, we can see a rapid improvement in their symptoms. We can also, as a primary stroke center, we can assess if this patient could need a mechanical thrombectomy. So what that is that if after doing the CAT scan, the CT scan, and we do something called a CTA, which is a CAT scan, but it's also with a dye, so we can see the blood vessels in the brain. If we notice that there's a large vessel in the brain that is occluded, we can actually assess them and make the call that this patient might need a thrombectomy, which is basically going in and removing that clot. So we can transfer them. Yeah, so we can transfer them to an acute care facility that will be able to perform that mechanical thrombectomy. So here as a primary stroke center, we can decide if this patient could possibly need a mechanical thrombectomy. So that's for ischemic strokes, right? So we can give TNK. We can also decide if they might need a mechanical thrombectomy. If it is a hemorrhagic stroke, so that's with the blood vessels that is bleeding in the brain. So what the treatment for that includes reducing pressure in the brain, because when the brain is bleeding, the person's blood pressure would shot up. Think about a balloon that if you put too much air in the balloon, it will burst. It will make a huge noise. It's like the brain. If the pressure increases too much, if it's too high, can burst, there's bleeding, and that pressure would keep going, skyrocket. So we want to give that patient, that person, enough medication to reduce the pressure in the brain. So we'll give them a lot of blood pressure medication to decrease the pressure in the brain. We will also transfer them to a facility where they're able to get a surgical intervention done. We also have a neurosurgery team when we can stop the bleeding to be able to save the brain. Because ultimately, that's the big picture. We want to save the brain so we don't end up with lifelong deficits, lifelong disabilities, and that can affect you for the rest of your life. And for the third most common type of stroke, which is a TIA, the mini attacks, so treatment for that includes preventative care, because we want to prevent a big stroke, right? There are warning signs, there are many attacks. So you want to give them antiplatelet agents or anticoagulations. So like aspirin, for example, is a common one. If the patient has high cholesterol, we want to make sure they take their cholesterol medication. If they've been diagnosed with diabetes, we want to make sure that those vessels, they stay healthy. So with stroke, we want to think about cerebrovascular health, right? If your blood vessels are healthy, their risk of developing having a stroke in the future, it goes down, right? So we want to make sure that if they smoke, that they're practicing smoking cessation. If they have something called AFib, right, which your heart, instead of your heart squeezing like regularly, it's now fibbing, right? So when your heart fibs, it squeezes very fast, which can dislodge a clot that can go and block the artery, like I was saying before, which can lead to a stroke. So it's very important that we prevent that. So staying on top of your cholesterol, getting exercise, and having a heart healthy diet, being able to eat your vegetables. If there's any diagnosis of diabetes, AFib, high blood pressure, staying on top of those medications is how we can prevent ultimately a bigger stroke after the patient has a TIA.
So I think you sort of answered my next question, which was that, who are most at risk? And so obviously people of a certain age, people who have cardiac issues, diabetes issues, and who maybe are not compliant taking the medications that they need to take for those things. But what about, is there a genetic risk factor?
Right. So with stroke, there is modifiable risk factors and non-modifiable risk factors. So modifiable risk factors are things that people can do to change to make sure that they don't develop a stroke. And as terms of the genetic, there's non-modifiable risk factors, which includes if you have a family history of a stroke, right? So if you have, for example, your parents had a stroke, your grandparents had a stroke, you're more susceptible for having a stroke. So these are things that you cannot change, right? As well as if they're a specific race or gender, you're more susceptible for having a stroke. So these are non-modifiable risk factors because it's not based on whether they exercise or they smoke. It's just based on who
they
their
are.
genetic. Yeah, basically. So with those non-modifiable risk factors, it's very important that they follow with their doctors, making sure that they stay on top of their blood levels, checking to make sure that their cholesterol stay managed, to make sure that if they do develop diabetes, to make sure that they are on a proper regimen that controls the blood sugar, right? Or if they have any heart disease, if they have something called AFib, to make sure that they are on a proper blood thinning medication so they don't develop a blood clot that would eventually clog an artery and can lead to ischemic stroke.
So, I think a lot of people of a certain age, I'm in that age group, I think one of the things that occurs to people in my age group and older is how quickly can you recover from a stroke? And are there things that are there light strokes? Are there really catastrophic strokes? I mean, what's the prognosis? I guess is the long way of asking this question. But what is the prognosis for people who have strokes?
Right. So without going too much into the medical diagnosis, recovery time, it varies widely depending on the stroke severity and the location of the stroke in your brain. So, as well as the speed of the treatment. We spoke about if you get here within 4.5 hours of the last time you were feeling normal, we can give you that clot busting medication if it is an ischemic stroke, right? If someone comes in within 2 hours, they've received the medication, their symptoms resolve. Now this person might be left to little to zero deficits. So no disability, they're able to continue on with their activities of daily living, cooking, and anything else that they enjoy doing. But if they delay into coming into the hospital and they come in and the only thing we can do is manage their deficits, manage their disabilities. So the lifelong recovery, it will be more complicated than someone who came in faster. So with that, some people may recover fully in a few weeks. Others, they might need months or years of rehab, physical rehab, speech pathology, emotional health, all of these potential challenges. They will have to go through rehab and to regain their strength back, to regain their abilities to speak back. So one, it depends on the location and the severity of the stroke, of course, as well as the speed of the treatment, which is why FAST is such a popular and very crucial acronym because it tells everyone to make sure we get help fast in a timely manner so we're able to prevent those lifelong deficits.
So lifelong deficits are what? So what is affected lifelong?
Right. So, for example, a disability is different than a deficit, right? A disability is, for example, you're not able to use both of your hands the same. That's a disability. A deficit is how it affects your life. For example, if you were a chef or like if you like to cook, right? And you're not able to use both of your hands, that will affect you differently than just someone, anyone that just the disability is just you can't use your hands, right? Your deficit is how it affects your life, right? if you were perhaps a secretary, administrative staff, and you're not able to use the keyboard, and now you can't go to work anymore, or you have to think of a second career. So that would affect your life um, harder than someone who, for example, was an athlete. So deficit is really how it affects your life, how that disability from the stroke affects your life as a person. So we want to prevent that, because ultimately, after having a stroke, first we want to prevent someone from having a stroke, but also after someone eventually, if they do have a stroke, we want to make sure that they're able to go back to having, the life that they had before, without feeling that this disease has impacted their lives.
Okay.
So
So it's very interesting, because I know in your bio, you're studying about the mental health consequences of having a stroke, sort of living with not only the disability but the deficits, as you've explained. Can you talk about the mental health for these patients who do end up with these disabilities and these deficits, and what's
Yes.
possible for them?
Yes. So after someone have a stroke, it can significantly impact their mental health. It can lead to issues, but they're especially stroke patients are more susceptible for these issues because their brain has already been affected, right? So they can have develop symptoms of depression, anxiety, as well as emotional changes because of those impairments, cognitive impairments, right? So it may affect their memory and their thinking skills. So it's very important that after someone have a stroke, that in addition to every single member of the multidisciplinary team that takes care of that patient, if the symptoms suggest any of those things that I said before, like depression, anxiety, emotional or cognitive changes, that they follow with a mental health professional to make sure that they are on a proper regimen. For example, SSRI, like a medication that would help them with their serotonin levels. So if they are feeling less depressed, they're able to be motivated to go through rehab, to go through speech pathology, to go through physical rehab. And with rehabilitation, they're able to gain that strength back, right? So if you're happy or if you're in a better mood, you're more likely to be able to attend rehab, and where you can be motivated to work out and to eventually gain your strength back. But if they're depressed, they yeah.
So that's very interesting to me, because I do think that when that's something I wanted to talk about, the things that people do as part of their rehab. But if you are feeling those emotional things, and you're out of control of your own life or your own body, how that affects you mentally also then affects whether or not you're able to continue forward with your rehab. But you named a few things. So can you kind of go back and just talk a little bit about those physical things? Because I think that's part of the plan. And isn't that important for patients to have a plan? And so in part of that plan, they should not obviously forget about the mental health aspect, as you were saying, but what are the other things? You mentioned a few types of rehab. Give me a little bit overview on that.
Right. So there are different resources available for someone after they have a stroke. So that are the rehab services. We have support groups, we have educational materials, we have counseling. So our hospital provides different rehab programs that we can recommend and refer stroke patients to, as well as local and national organizations. They offer a wide range of resources to support patients, to support the families, because we also have to remember that families are greatly impacted after their loved ones develop a stroke, because now it changes their abilities to even be in the home and and continue to be themselves. So the families also need resources. So those local support groups, as well as support groups for the patients and the caregivers, they're very important in the recovery process of a stroke. So it's a community effort, it's a local effort, it's a national effort in the recovery of a stroke, which is why we have different organizations, just as in the country, that really helps with the recovery of a stroke patient.
Very good. So we have a question from our audience, and I love this question because this, I think, speaks to the heart of why people wait to come in. And the question is, we might be reluctant to go to a hospital with a suspected stroke because we don't want to bother the personnel. How do you all feel if it's a false alarm?
If it's a false alarm, we are grateful that it is a false alarm, because that means that the person is able to go back home and continue on with their lives. And it's also a great opportunity for us to educate the person. So we are never bothered by someone coming into the hospital for thinking that they were possibly having a stroke. If anything, we want to use this as a opportunity to educate the community so they know the warning signs of a stroke. We would rather you come in and rule out a stroke and everyone goes home and they're happy, versus you did not come in and now the brain is more affected, and now that person has to be left with lifelong disabilities. So we don't want that. So we would rather you come in. You're never bothering anyone here at the hospital. If anything, it's an opportunity to educate you, the community, because you're able to educate your family members, your friends, and you can spread the word, because stroke is a very, very common thing that impacts everyone.
That's a great answer, because honestly, always err on the side of caution. I just want to reiterate what you said, Dominique. I mean, I think it's so important for our community to understand that is why the emergency department is here. We're not clinicians. We're just people out in the world. And when we don't feel well, I'd rather know that it's not a stroke, because as she pointed out, you gotta be fast. You gotta be fast. So Dominique, is there anything else that you'd like to add that we didn't cover? Or I think we let's do face again, fast again. Face, arms, speech.
Time.
Time. Oh,
Yes. So move
okay.
fast, call 911, get help, go to your nearest emergency room and get help fast. So we're able to get a scan and decide how we're going to be able to treat this stroke or possible stroke.
We have another question from the audience. So when should you put a person in the car and drive her to the hospital rather than call 911? What are your thoughts about that?
For me, it's always safer to call 911. It's always safer to call 911 because they are trained personnel, right? For example, if someone fall, right, and you think you're helping them by picking them up, but depending if they've injured, for example, their spine, you might be doing more harm by picking them up versus calling 911, where you can have a trained personnel who studied the anatomy of the spine, who knows that there's a special way of picking someone up from falling, right? So we think that something simple like this person fell and now I want to help them get back up. No, it's always safer to call 911, get a medically trained person there to assess the situation and to be able to take them either to the safest place to be able to provide the care for the person. So ideally, we always want someone to call 911. Of course, if you're walking and you're right in front of the hospital, you can, but it's always safer to just call 911.
Right. I have to reiterate that as well. I mean, I think that people don't realize the severity of something, and they are bound by the traffic laws, and So it's better for the ambulance who know how to get someone there fast, going back to our fast, and safely. And that would be the better way to go. So if you have hesitation, to all of our audience members, please put that away. Come to the emergency room or call 911. Dominique, thank you so much for your time today and for sharing your knowledge with us and our audience today. We really appreciate it. If anyone in our audience would like more information, Dominique Petit Frere is our stroke coordinator and clinical resource. So her number is 964-8889. That's 914-964-8889. And then if there are other questions, I don't see any right at the moment, but if there are other questions, always feel free to write to me at info@riversidehealth.org. I will make sure that they go right to Dominique, and we'll get you some answers. And if you do need a physician, if you are feeling a little off, please call our physician referral and get a good primary care doctor or specialist, whatever you need. And that number is 914-964-4DOC or 964-4362. We do have a Spanish-speaking physician referral line, and that number is 914-964-4245. Again, if you have questions or you need that information, feel free, info@riversidehealth.org. And thank you all to our audience and to Dominique and to my staff for putting together another wonderful webinar. We appreciate you, and we'll see you soon.